What's up, everyone? Today I'm doing a rapid review of glycogen storage disease type 2, also known as Pompe disease. Pompe disease is an autosomal recessive inherited metabolic disorder. It's unique among the glycogen storage diseases because it's also classified as a lysosomal storage disease, or LSD. It's caused by a deficiency in the lysosomal enzyme acid alpha glucosidase, or GAA, which is encoded by the GAA gene. This enzyme is essential for breaking down glycogen within the lysosomes. A quick tip: if you see the word acid in front of an enzyme name, that enzyme is almost certainly lysosomal, and the associated condition is likely a lysosomal storage disorder. Now, a deficiency in acid alpha glucosidase leads to the intralysosomal accumulation of glycogen, primarily damaging cardiac and skeletal muscle tissues. Now, there are two major phenotypes you need to know, distinguished by the age of onset and the presence of heart involvement. The first is infantile onset Pompe disease, or IOPD. This is the most severe form. It typically presents within the first few months of life. The hallmark presentation includes profound hypotonia, often called floppy baby syndrome, feeding difficulties, failure to thrive, and respiratory distress. A classic high-yield fact for your boards: these infants present with massive cardiomegaly and hypertrophic cardiomyopathy, which can lead to early death from cardiorespiratory failure if untreated. The other form is late onset Pompe disease, or LOPD. This form can present at any time from late infancy to adulthood. It's characterized by progressive proximal muscle weakness, similar to limb-girdle muscular dystrophy, and respiratory insufficiency due to diaphragm weakness. Unlike the infantile form, significant cardiac involvement is typically absent. Diagnosis is established by demonstrating deficient acid alpha glucosidase enzyme activity in blood, often via dried blood spot, or skin fibroblasts. Confirmation is typically done via molecular genetic testing to identify biallelic pathogenic variants in the GAA gene. Management has been revolutionized by treatment, but it remains complex. Key management strategies include enzyme replacement therapy, or ERT. This is the cornerstone of treatment, and it's the intravenous infusion of recombinant human acid alpha glucosidase, such as L-glucosidase alpha. This can improve cardiac function and extend survival. Then there's CRIM status. Before starting treatment, it's vital to determine the patient's cross-reactive immunologic material status, which is CRIM status. CRIM negative patients produce no enzyme and may develop high antibody titers against the therapy, requiring immune modulation. Then there's supportive care. This includes physical therapy for muscle weakness and aggressive respiratory support, such as BiPAP for hypoventilation. And lastly, there's surveillance. Routine monitoring of respiratory function, including sleep studies, cardiac status, and antibody titers, is essential. And that's your rapid review. Hit that like and subscribe button for more quick study tips, and I'll see you next time.